Evening, wherever you're joining us from. I'm Bernadette Kumar, and I'm the chair of the Global Society on Migration, Ethnicity, Race, and Health. And along with the Center for Immigrant, Refugee, and Migrant Health at CUNY, New York, I'm very pleased to welcome all of you to our webinar today. As we know that migration health is really a defining issue of our time, and it has been over the decades proven to be more and more important. However, we know that attention has not been given to migration health as much as it deserves. In 2018, about 750 scholars, civil society, researchers, policymakers, and others gathered in Edinburgh. And the Edinburgh Declaration really led to the initiative about the Global Society, and that's when the work with the Global Society was initiated. The Global Society has been working together with colleagues across the planet on migration health issues. And most recently, we're very pleased to say that a working group on the Big Cities initiative was established and led by the Center for Immigration, Refugee, and Global Health at CUNY. And I'm also very pleased to say that it is through their efforts and this working group that this webinar is being launched and the initiative is being launched today. So I'm not going to give you a very long talk. I'm just going to say I'm so delighted and pleased that so many of you have prioritized attending this webinar. And without much ado, I'm going to introduce Kathleen Cravero, who's going to chair the webinar today and give you all the instructions for the rest of the webinar. So Kathleen, over to you. And thank you for organizing this.
Thank you very much, Bernadette, and thank you for all your support and help in identifying excellent speakers and shaping this first session. I'd like to join Bernadette in welcoming everyone to the webinar. I am Kathleen Cravero from the Center for Immigrant, Refugee, and Global Health at the City University of New York School of Public Health. We first started thinking about this idea of the evolution of migrant health during crises, as we are the biggest public school of public health, probably in the United States and beyond. And we were watching what was happening to migrant health in New York City during the pandemic. And we wondered if other big cities were experiencing the same kind of challenges and what approaches they were taking. So we did a systematic review looking across a number of big cities, touching every region to try to get an idea. And that brought us into touch with a number of researchers working on similar subjects across the world. As Bernadette said, we hope this will be a series of events and webinars as we shine a brighter light on the evolution of migrant health policies in large urban areas under the framework and aegis of the Global Society for Migration, Ethnicity, Race, and Health. So today we're going to start with Lisa Hitch just giving a very short introduction to our systematic review, but then we have 4 speakers who I will introduce one after the other, who will focus on a different aspect of the evolution of migrant health in crises and what that might hold for the future, or what lessons that might hold for a future and how we might apply them. So each speaker will address an introductory question for about 8 to 10 minutes. And then at the end of that, we should have plenty of time for questions. And I encourage you all to put questions in the chat. We'll be moderating that closely and come to those questions at the end of the webinar. So, without further introduction, I think I will introduce Eric Brioso. Erica is a PhD candidate at the University of Ispa in Portugal. Her research focuses on the integration of refugees and migration detention in both Portugal and Italy. She works extensively and has studied extensively civil society organizations and their contribution to integration and health policy around migrants, and is living, working, and studying in Lisbon, and will highlight for us today some of the aspects of integration, migrant integration and health policy in that city. So over to you, Erica. And I would like to start, just to say, I'd like to start with the overarching question to Erica, which there is an impression that Lisbon took a more inclusive approach to migrant health during the pandemic. And I think we'd like you to start by just indicating whether your work supports this and what were the key drivers and dynamics of the evolution of migrant health policy over the last 2 to 3 years.
Okay, thank you. Thank you to all the people here today. Thank you, Professor Kathleen, to invite me, and thank you to Lisa to invite me to somehow briefly unpack the Lisbon case. I think, it was implemented by the civil society, very inclusion practices to face the pandemic, but I will explain in my brief presentation in more detail. Okay. So, can you see? Everyone can see? Okay. So one aspect that characterized the Lisbon case is the overcrowded situation of spontaneous asylum seekers in Oslo in the center of Lisbon. The overcrowded situation did not arise with the pandemic, it being a situation present for a long time and announced by the main refugee-led organization Forum Refugee in Lisbon. Also, are just one point in case due to also the very challenging Lisbon housing market. The failure of temporary accommodation in human conditions suggests that the institution bonded with the reception of refugees adopted practices that do not allow people to live in hygienic condition and thus expose them to a greater risk of health problems. And given the large number, many health needs were neglected. As a result, 138 asylum seekers tested positive to COVID-19. So the hostels, the transformation also of the OTA military base into a temporary reception center to provide an emergency response to the overcrowded situation occurring in the hostels, but also the wider institutionalization of accommodation in CARS, refugee reception center, are paradigmatic of the unpreparedness on the part of the institution responsible for dealing with health emergency on the one hand, but also provide access to health services in a non-emergency situation, so the preparedness about in an emergency situation and not in a non-emergency situation. Conversely, and interesting, the great capacity for self-management on the part of civil society call into question the institutionalization of settlement, recognized as generating a condition of dependency. Indeed, this kind of institutionalization of reception and settlement has no reason to exist. These practices should exceed the institutional accommodation and avoid any kind of trans-institutional accommodation practices. The pandemic could be a call for other formal housing based on social networks that develop informally between different agents and that co-produce, co-manage, share resources, time, services, knowledge, information, and support on the basis of solidarity and reciprocity rather than economic profit. So more collective, the institutionalized and community-based modes of accommodation practices and housing are one of the transformative changes emerging from the pandemic that could lead to transformation in access to health services. The active role of the civil society is a cut-crossing team. While it's true that state did carry out somehow some program action They were not always on its own volition. Indeed, in many ways, the state have to have its arm twisted and be pressured into instituting these reforms by Forum Refugio organization, advocate on behalf of people on the move. In response to COVID-19 emergency, the Forum Refugio, as you can see in this slide, put in place an emergency plan called the Plano di Apoyo Refugio no Contesto di Emergenza, financed by High Commission for Migrant, ASEM, another foundation, Carlos Gulbenkian, and managed by the Association Union of Refugees in Portugal, Europe. Within the plan, an open letter to denounce the unacceptable situation refugees find themselves during the pandemic was written also. To plug the structural gaps in the healthcare system, such as the lack of information, for example, different supports such as cultural mediation as well as others were provided. So the importance of cultural mediation surfaced, corroborating what Portuguese academic, especially one, Cristina Santinho, have been stating for over 10 years, namely the mandatory systemic implementation of translator while attending health services to the westernize, decolonize the services and provide a more person-centered services. The contingency plan was supported by limited resources. Those identified as most vulnerable were the beneficiaries of the emergency plan. This without detracting from the great response from the refugee-led organization Forum Refugio, merely mirrors the structural health care gap within the asylum system that is not systematic at all, but rather reactive, able to deal with the situation as they arise, a kind of triage in face of constant crisis. The pandemic has taught us that the presence of different services, is not sufficient to respond to health emergency situations such as the COVID-19. As much there has been motivation, intention on the part of the local municipality of Arroyo, which implemented a project called Aura to respond to the holistic needs of people in the hostel. This would not have been occurred without the intervention for Refugio, who report the situation of the hostels first and knew the multiple challenges people were facing, even before the pandemic, on the basis of previously established contact and proximity. And from the last evidence, we draw the third lesson of the pandemic, recognize the active role of the community of refugees and asylum seekers, and the urgent need to transform Portuguese asylum policies and practices was shortcoming are too often fulfilled by grassroots solidarity organization. As we have seen further from the pandemic, these organizations are indeed the main sources of informational, material, and emotional support. Transformative change can only be pursued through the active participation and leadership of refugee-led organizations and policies, whose agency and right must be acknowledged. But however, equally necessary and is the interagency between refugees-led organization, refugee people on the move population, and already pre-existing resources and services in the community. During the pandemic, to end, we witnessed a more general unblocking of the health system. So many migrants, refugees, asylums had access to a health number and vaccination for COVID-19. So we can understand that the collective response during the pandemic means that cross-cutting and intersectional health policies as well as structural solutions with collective horizons need to be addressed in the future, looking at the refugees' health needs as a national health issue and not just a refugee-related issues. As the Forum Refugio coordinator said several times, This is not a refugee during the pandemic. This is not a refugee emergency. It is a global one. Thank you. Sorry.
Thank you very much. Thank you very much, Erica. I think a couple of the themes of that were the underlying inequities that were present before the pandemic struck, and the role of civil society, both in providing services and as advocates in this setting. So thank you very much, Erica. I'm sure we'll come back to some of those points. I'd now like to turn to Dr. Marie Noordam. Dr. Noordam is the director of the Danish Research Center for Migration, Ethnicity, and Health, and professor of Migration, Ethnicity, and Health at the University of Copenhagen. She is an infectious disease specialist, and her research focuses on health equity, migration, and access to health among migrant populations. And Dr. Noordam will talk a bit more broadly on the Denmark-wide level about some of the policies that were put into place to meet the challenge of recent flows of Ukrainian migrants into Denmark. So I'll ask Dr. Noordam to address the following overall question in her opening remarks. Similar to other countries, Denmark has welcomed large number of Ukrainians over the past several months. What have been some of the key challenges in the reception of Ukrainian refugees? And if so, how is this experience likely to impact reception policies in the future? Thank you, Marie Noordam.
Well, thank you very much, Kathleen and Lisa, for inviting me to speak here at the seminar. So this is going to be a bit on a different note, but also about how cities and municipalities handle migrant health. As to the key challenges when we started receiving Ukrainian refugees in Denmark, and I think they were the same in many other countries, but what we experienced was that around 25,000 Ukrainians came quite quickly and entered into Denmark. We have a normal population of some 5 million people, and by now around 40,000 Ukrainians live in Denmark. So the immediate sort of challenge and need was on a municipal level, and most of the refugees were coming to Copenhagen and larger cities. That was accommodation. So some could live with of course, with friends, and many Danish people also volunteered, but the majority were actually had to be hosted by municipalities in hotels and in other sort of larger buildings where there were rooms and facilities. And of course, it gave some problems when having to host, for instance, people with mental disorders that maybe had some other needs, with handicaps, with children, families with children, etc. So there were a lot of challenges for the local municipal workers here trying to accommodate to this large influx of refugees. Then, of course, regarding health, there was sort of an immediate challenge in trying to identify the health needs. And this was very much based on sort of the presumptions about health needs that were known from WHO and other publications about the Ukrainian population. And not least, there was a focus on infectious diseases, knowing that the incidence of HIV, of hepatitis C, and not least of multi-drug resistance TB was higher, or is higher in Ukraine compared to a country like Denmark, and that vaccination uptake, for instance, for COVID vaccination, but also for the child vaccination program was lower. And of course, also cardiovascular diseases, mental health disorders, exacerbated by being a refugee and having experienced traumatic events, was also part of the picture. Sort of that was sort of trying to get an impression of this was a next step, and then what kind of services to provide was the next challenge. And here sort of the problem was that there was a gap sort of between arriving, and many were picked up in Poland by Danish volunteers or came in other different ways to Denmark. But after they arrived in Denmark, and then until they actually applied for a temporary residence permit, which I'll get back to, there is a gap. This could take days to months, often about a month before applying for a temporary residence permit, because there was sort of a bulk of work for the people who had to go through the residence permits. So there was sort of a gap here where there was only really access to acute care like tourists. And here the municipal workers who were standing with these large accommodation centers, for instance, in Copenhagen, had to be able somehow to find ad hoc solutions. Here now, people had run out of medicine, who needed a checkup for chronic diseases, etc. These were things they were not really equipped to take care of in their normal work, and they very much depended on calling general practitioners, NGOs, and other people around them who could help in the concrete reception centers and accommodation centers with these health problems. So it could be somebody who had run out of medicine for HIV or for bipolar mental disorder, etc. And I know the municipality workers felt a bit left alone in this situation and left out of more national strategies. Then, of course, the next sort of challenge was how to provide more long-term care. Were we able to absorb some 40,000, or it was actually estimated some 100,000 more people with different chronic diseases, infectious diseases in our existing healthcare system, and sort of tested the system resilience also. And I'll get back to some of the responses here. And then I think the last thing, which was a challenge and was discussed very much, was whether to screen on a national level, make a systematic screening of people, well knowing especially that these infectious diseases were more prevalent, not least TB was a focus. Should this be done or should it not be done on a national level? And what happened here in the end was that it was decided not to make any sort of national screenings of all people who came from Ukraine, also because it was, the volume itself made it quite difficult, but to agree that once you have a residence permission, you get a general practitioner, and then the general practitioner was provided with special guidelines for Ukrainian refugees, and upon the first contact, they should then decide how much work up to do with the individual Ukrainian refugee. Apart from this, the municipalities actually decided that they were standing sometimes alone with some very difficult cases, and they were observing them on a day-to-day basis in these accommodation centers, people with handicaps, with chronic diseases who come out of cancer care or whatever, and they decided to select the most vulnerable individuals and send them for a individual screening on a more sort of fast track level, mainly to some immigrant clinics that are established around in the country, not least in Copenhagen. So that's how some of the challenges that we faced here. I'll go on to the next slide then. And having these challenges, so what did we do in Denmark? Well, we quickly followed up on the EU Temporary Protection Directive with a special Ukrainian law, as we call it in Denmark, that provided temporary residence permit to all Ukrainians who applied, and also family reunification for 2 years, the temporary residence permit with the possibilities of prolongation. And as soon as you had sent in an application to the municipality, to the state for getting a residence permit, well, then you were allowed full access to healthcare services. This was something very different from other groups of refugees that we have received in Denmark, where you have to have a residence permit before you have any full access to the system. What also happened of special initiatives that have not been taken to this group was sort of again on the three partners here were the national level, the regional level that runs the hospital, and again the municipality levels where the big cities where Copenhagen, etc. are part of. And here the National Board of Health, which have kind of over quite some years been a bit silent about refugee and migrant health, very quickly established an expert group. I was in it myself. High profile leaders from the National Board of Health, director level, were included in this expert group. The hospitals also established expert groups, and the national expert group with the National Board of Health, their expert group very quickly developed specific guidelines and decided on the screening strategy that I explained just before, being implemented by the general practitioners, and a vaccination strategy with special vaccination clinics for Ukrainian refugees. This was followed up as it was the GPs taking care of the screening very quickly, organizational negotiations about how they could be paid, etc., for doing this extra work was also done. On another note, special acute clinics for Ukrainians in the capital region and other regions were established. Psychiatric hotlines were established very quickly, and also just general regional hotlines were established. This was not done with Syrian refugees, for instance, or other groups that we have received. So all these were specific initiatives, very good initiatives, I think, that were tried in case of the Ukrainian refugees. Special information was provided and made in collaboration with Ukrainian refugees, and also there was a focus on getting as many Ukrainian interpreters. One saw that was a problem, but getting that as quickly as possible. And I'll just go on to the last slide. So I think what we've learned and what we can maybe use when Kathleen asked about that for future policies is that just like with COVID-19, actually, we were able to establish our response quite quickly, collaborating different authorities together. And we were kind of flexible, agile, dynamic in doing that, quickly at making guidelines and also in implementing some concrete initiatives like the screening at the general practitioner, like the acute clinic, especially with Ukrainian interpreters, etc. And this was all supported by a legal framework that was in place very quickly. I think some of what we should learn forward was that actually the municipalities were sometimes left somewhat alone with actually they were the ones, you know, there might be policies, etc., quite quickly established, but they were actually dealing with the day-to-day problems, not always with so much professional support, and many social workers had to deal with, for instance, a lot of health problems. Another thing I think we've learned is that and I think we need to discuss that, was this differential treatment. All of a sudden, there was a group of refugees that maybe we could identify more with, being Europeans, being nearby, being a war that might affect us, etc., in our region. And it was all of a sudden, there was set this good example with how things could be done, how flexible and dynamic and etc. the whole system could be overall, which we didn't see, for instance, with the Afghani interpreters, who's a larger group we've received quite recently, or with Syrian refugees. So I think going forth, we should, of course, try to evaluate what's happened so far, and of course, learn that we can really make a very feasible and dynamic response. And why shouldn't we do that maybe to other groups also? I think is something that's important to carry on to future policies also. And I think that was my input here about the Ukrainian refugees.
Thank you very much, Marie. I think the description of the challenges and how they were responded to quickly, with collaboration, with flexibility, with clear guidelines. And the key question, which we probably can get to in the discussion, is if that can be done for one group, what are the implications going forward, and more general reception policies for refugees? So thank you very much. Now, the next speaker is Dr. Nabila Ahmed. Dr. Ahmed is a human geographer at the Sheffield Hallam University in the United Kingdom. She works at the intersection of urban studies, governance, and precarity in post-colonial contexts, citizenship, and state welfare. She also looks at gender rights among labor migrants and access to digital technologies. And Dr. Ahmed has been working on migrant rights and access to infrastructure in South Asia for over a decade. And I think that she's a very a perfect person to address the next overall question, which is the following. There were unprecedented flows of people within several countries during the pandemic, notably India. What were the underlying causes of these massive flows of people that most of us saw real time through the media? And has anything been learned that might mitigate these problems in the future? So over to you, Nabila.
Thank you so much, Kathleen, Lisa, and Bernadette for this opportunity, and welcome everyone. Thank you so much for joining us. Lisa, thanks for putting up that first slide. So I'll try to somewhat answer your questions, Kathleen, very good questions, in the following that I prepared. So when we think of the various national lockdowns that were launched in early 2020, a common image that might be summoned to our minds is that of empty cities, bare public spaces and streets, a complete shutdown of commercial activity and basic public infrastructure such as transport, and just this idea of being trapped and immobile in a domestic space. But as you can see from these images, hopefully on the screen, this was very far from the situation that unraveled in India. After the first COVID lockdown was announced overnight in March 2020, that's going to be basically the focus of my brief intervention today. So just a little bit of background on internal migration, which is a little bit different from some of what we've seen discussed so far. Scholars argue that migration is often thought of as solely an international phenomenon, but actually estimates from the UN and IOM from around a decade ago, so I'm sure it's increased even more since then, indicate that the total number of migrants moving within national borders of countries such as China and India actually outstrip by far the total scale of global migration. And so there are many lessons to be learned from internal migration in terms of public health and beyond that come to light, particularly in populous, large countries with national federalized regimes, like that of India, where different states, like we've seen in other countries, including the United States, where there's almost this tussle between central government and local government responses in terms of the COVID-19, and also the distribution of resources. And it's often the most vulnerable, such as labor migrants, who lose out the most from this tussle. The actual scale of internal migration and the role this plays in making Asian cities, including those in India, megacities like Delhi, Bangalore, Kolkata, and so on, they're among the fastest growing in the world, and this needs to be recognized. And just to give a bit more background, there are about 300 cities with populations of over 100,000. 7 of these cities, according to the latest data, exceed 3 million, out of a total of about 4,000 urban centers in the country overall. So there are several internal boundaries and borders for migrants to move across for work, even within an internal kind of national context. And estimates from the latest interval data since the last census indicate that there are about 600 internal migrants in India today. These are estimates, which is up from 450 million migrants enumerated in the last census, which was in 2011. And if we go to the next slide, you can see some of these estimates graphically presented, and you can see that decadal increase, they're broken down for gender there as well, in internal migration. So it's the scale can't be ignored, and urbanization, the presence of big cities, the theme of this workshop today, is due in large part to this rural to urban migration. So you can argue that migrants are the backbones of India's cities, yet they're invisibilized and excluded. Not only do people not really have an imagination when it comes to internal migration, for the reasons I already said, but you can't ignore the fact that most of India's megacities today and the infrastructure that runs them is based on labor conducted by migrants. And most strikingly, this invisibilization is present in terms of adequate data on the scale and numbers of migrants, on the composition of gender, on things like caste, age, class background. These are very poorly understood at the official scale, and it's often down to scholars and demographers like the ones that are cited here in this slide to try and do that extra work to get an estimate and a picture, basically, of what the migration patterns are today in India. It also demonstrates a lack of policy commitment and attention at the central and local scales to migrant health and welfare, despite the fact that we're talking about Indian citizens who have a constitutional right to live and work anywhere within the city. So unlike other contexts that we've looked at in Portugal and Denmark, these are migrants who are citizens as well, who don't face necessarily some of the barriers you might face as an international migrant or refugee in a new context. Another thing to really consider is that India's urban and industrial expansion is strategically and historically reliant on cheap migrant labor from rural areas. And these are also reinforced by forms of control that are rooted in historical systems of gender and caste and class and religion and so on. The kind of labor that these migrants are typically employed in are among the most dangerous and socially stigmatized forms of work. So, for example, construction in risky work environments, sanitation, domestic work, particularly for women, and so on. So there are health risks endemic to this kind of labor in any case. For example, there's some evidence recently gathered in Western India on the long-term health impacts on respiratory and lung damage among stone cutters and stonemasons. So these have existed long before the pandemic due to the very nature of the labor that migrants are engaged in. And in addition, there's extensive evidence on the impact of the lack of access to social protection and state support, as well as adequate wages on things like household food security and nutrition, and lack of amongst migrants and their families. So these are deep-rooted disadvantages, which have meant that despite a raft of legal and social protection kind of frameworks in India, migrants remain excluded from accessing these. So for example, and Marie's mention of this in Denmark, a fixed proof of address, in other words, an ID document or card, is required to access a lot of these state subsidies, including things like state support, including things like food subsidies and healthcare, despite the fact that many of these labor migrants that you saw in the slide before and that I've been working with for the past decade or so live below the poverty line. So they are eligible for such programs, yet remain excluded. So in terms of the pandemic itself, we can go back to the original slide, just to bring home what I'm talking about. When India announced a national lockdown for 21 days in March 2020 in response to COVID, the government declared that citizens need simply to stay at home. But for millions of internal labor migrants in Indian cities, this meant an abrupt loss of livelihoods, of income, of wages, pretty much overnight, a lack of access to social protections and relief packages, and being forced to return home, if you like, to their villages, often in the absence of public transport, having to travel hundreds of kilometers on foot. And you can see this kind of represented in in the image on the right-hand side, or rushing to, using the last of their wages to travel on unsafe and overcrowded transport back home, risking hunger, destitution, and disease. People gathered in public spaces, desperate for food, or used up, as I said, the last of their wages to travel home in unsafe conditions. And in many cases, some of these migrants in the early days were greeted in their home states with further dehumanizing treatment, so being detained in deplorable conditions, or literally being hosed down with chemical sprays in a bid to ostensibly stop the spread of COVID. So suddenly this invisibilized population that I referenced before, many of whom are women and children and among the most vulnerable, were thrust into the spotlight, into media headlines, not just in India, but obviously all over the world in an already bleak news cycle. And this highlighted the sheer lack of preparation of the state in response to the crisis, which I think answers the question, how did we see these unprecedented numbers? It's because there was a lack of understanding and preparation from the state, or foresight, if you like, that this was going to happen. And an underlying lack of understanding about even the most basic patterns of migration, right? Where do people come from? How far did they travel from home? How were they migrating alone or in families, and so on? So this inadequate response was actually mirrored in ensuing smaller state level lockdowns in the following months. And obviously you may know that in 2021, the Delta wave of COVID was actually the most devastating wave of COVID in India. More so than the first wave in 2020. But you saw that actually lessons weren't really being learned on the short-term basis and actually replicated, or the same kind of problems were being replicated, or albeit on a smaller scale. So as of early 22, which is when I last published on this, there was still no full understanding at the state level of the number of migrants who were displaced due to COVID, nor the number of fatalities that can be attributed to the lockdown itself, right, rather than COVID. So deaths due to hunger, due to accidents on risky transport back to villages, there's still a large unknown mystery surrounding this. The state came up with an estimate of around 11 million return migrants, but many experts agree that this is a gross underestimate. Migrants remained ineligible for relief packages that the government eventually did introduce, things like food subsidies, financial support, etc., healthcare, due to the very same reasons they were denied access due to the very same reasons that they've been historically locked out of social protection, i.e. lack of documentation, lack of adequate proof of identity, etc. And what activists, advocates, civil society, and academics like myself have shared consensus on is that the pandemic response from the government actually only highlighted and exacerbated existing issues that have been faced for decades by migrants in big cities. So just the last few minutes, I want to talk about responses and solutions. And for that, we can go back to the data slide, because that's probably one of the biggest data, meaning the graph on slide 2. That's probably what most people agree upon in terms of, that's probably agreed on as the most effective solution, longer term solution for these kinds of crises. Data, they're rooted, we need better data on the sheer scale and characteristics of migration operating within India. And we need clarity on the scale and the character of migration. Who, how, why are people migrating? What distances are they traveling? Who are they taking with them, etc.? How do they live their lives? And how do they strategize in the face of challenges such as lack of access to social protection or healthcare and so on? And how do we best support migrants through this understanding, through social protection packages, through welfare assistance, through healthcare, locally available healthcare, etc.? This data is required to provide a robust underlying infrastructure, the best of times, let alone in times of crisis, for providing relief. A national labour migrant policy is actually in play, is in the works right now at the national level in India, and lessons can actually be drawn from the ways in which Indian migrants, labour migrants abroad are treated and protected. For example, everyone's talking about Qatar right now, home of the World Cup right now, where there's a lot of migrant workers from South Asia who are protected somewhat, or at least ostensibly protected, in ways that actually go beyond the ways in which internal migrants back home in India are protected. So there are lessons to be learned from international migration for internal migration. And though measures such as food relief and, as I've mentioned, social protection packages, and even specific rail networks, specific trains that were operating to carry migrants home, they were introduced too late. So again, not only a lack of foresight, but a lack of urgency of action is another reason that's been attributed for this kind of migrant crisis that was triggered in immediately after the pandemic. So to sum up, sustainable solutions that address these structural, long-standing barriers in terms of law, in terms of adequate housing and provisions in cities, and access to welfare and social protections, as well as improving livelihood conditions and the very quality of working conditions, can address and create opportunities for improving public health both in the short and the longer term, I imagine. I think, and taking a holistic view to migrant public health by improving access and coverage for populations who are mobile, for better interstate coordination within a federalized state like India, as well as clear central state directives are key for protecting against both long-term and short-term health crises. I think, yeah, thank you.
Thank you very much, Nabila. I think at least 4 real strong messages come from what you said. The first is the scope of internal migration. The second is that underlying inequities and discrimination and reasons for lack of access, again, were exacerbated during the pandemic. And the third is the sheer lack of preparation, understanding, and knowledge about the migrants living in cities and what their situations were and what their reactions would be. And fourth, how can we ensure that these lessons and some of what we know cause these problems are actually applied in the future? And that's you offered some suggestions for that, but it remains something that requires further discussion. So thank you very much for those key points. And now we'll turn to a regional perspective with Dr. Marcia Vera Espinosa. Dr. Vera Espinosa is a senior research fellow at the Institute for Global Health and Development at Queen Margaret University in the UK. She leads the Psychosocial Wellbeing Integration and Protection Research Cluster at the Institute. She's part of a collaboration of researchers looking at migrant integration and related issues across Latin America. And she has looked a lot and has researched extensively around inclusion and migration governance in Latin America and beyond. So to Dr. Vera Espinosa, I asked the question, your work spans several countries in Latin America. What have been some of the key similarities and differences among these countries in terms of their approach to migrant integration and migrant health? And what can be learned from these similarities and differences? So over to you, Marcia.
Thank you so much, Kathleen. And thanks also to Bernadette, Lisa, and Kathleen for facilitating this space for this question, but also for the opportunity to discuss about some cross-regional ideas, because I've been learning a lot about what Erica, Marie, and also Nabila have said, and I can see some similarities and difference as well, what happened between the situations that you discuss in those particular countries and what happened in Latin America. And as Kathleen mentioned, the brief reflections that I want to share with you today are part of a project conducted with colleagues of the research group Caminar, which is Comparative Analysis on International Migration and Displacement in the Americas, in which we wanted to explore the impacts of the pandemic and migrant refugee population in Latin America. We did it with a fantastic group of colleagues in 7 countries of the region. And what we did is we used a common instrument of data collection where we conducted more than 70 interviews across 7 countries, including Brazil, Chile, Colombia, Ecuador, Mexico, Peru, and Uruguay. And we did this at the beginning of the pandemic. So the interviews that I'm going to be drawing data to share with you today were conducted between June and September of 2020. So basically we were into like 6 months of the pandemic, and they were just making sense of what was going on in the countries of the region. Now, while our research covers several means and markers of where we understand by integration and inclusion and how the pandemic impacts some of these areas, there's specific learnings related to migrant health that I would like to share with you, because it was also one of the questions that we included in our way too long questionnaire when we were discussing these issues with our participants. One of the decisions that we had to make early on, actually, and it was an ethical decision, is who we were going to interview. So at some point we thought that the pressures were too large in the migrant communities at that time. So we selected different key informants that included, government officials, local officers, so municipalities, just emphasizing the relevance of the municipality, as Marie also invited us to think about. We interview NGOs, international organizations, but also migrant-led organizations who also might have experienced some issues, and difficulties at that time, but at least they had a more structured support around them in order to participate in the interviews. And we asked them specifically as well issues related to access to health and health needs of the migrant population. Now, one of the things that I want to emphasize in terms of the learnings, and I'm going to go a bit more in depth in each of them, is some of the key similarities in all the countries. And this is related to the understanding of the multiple contexts of crisis. And I think this is good to emphasize because, of course, we have the context of the health crisis that came also with an economic crisis, with many migrant communities finding themselves outside of jobs, but also not able to pay their rent, so actually in homeless situation across many of the countries that we study. And by migrant population here, I refer mostly to, of course, Venezuelan displaced communities, also Colombian displaced communities, people coming from Central America, Haitian migrants are some of the key groups that compose this intra-regional migration that we have in the countries of Latin America. But there were other crises. So of course, the humanitarian crisis of the displacement itself is something to take into account, as well as other socioeconomic issues that the societies in the region were living. And this context of crisis is interesting because in a way allow to many countries from a governance point of view to frame migration as something that is exceptional. So the response to migrants' needs, including some of their health needs, is one of exceptionality in terms that is considered emergency support. We discussed this in a paper that we wrote with colleagues in terms of what type of subjectification of the migrant, figure this represents. So in some countries like Brazil and Uruguay, where access to health and other social rights was much more developed, we have migrants as subjects of rights. Basically, they are human beings that have rights to access different, services and rights themselves. But in other countries, like Chile, like Colombia, like Ecuador, and Mexico, we have an humanitarian subject where the provision of help is temporary and mostly in the context of the emergency. So this context of crisis is quite interesting, and this multiple crisis to understand how has been used to kind of normalize this exceptionality. Now, this relates to my second point. Is that in one of the key things, and this is a characteristic of Latin American countries, is that there are different gradients of access to health services and healthcare. So for example, countries such as Mexico, Brazil, Uruguay, and Chile, they guarantee access to health to migrant population, both those that are in a regular, but also in an irregular situation, which is actually a welcome, and that already is a lesson that we should consider, that there is guarantee in the legislation or through specific decrees. And here I have to emphasize the role that the civil servants, so the technical people working in governments have. In the case of Chile, this was not necessarily a measure taken by the government, but the technical body, working alongside the government, civil servants have been working for a long time. They managed to publish this decree that actually guaranteed this access to health. So it's not part of our legislation, but they managed to find a technical way to do it, which became very important. So who is in the shadows, independently of the change of government, is very useful and relevant for these particular wins. So particularly in the cases of Mexico and Uruguay, across all the interviews, despite the difficulties the migrant population was facing at that time and that the local governments were facing as well, no major issues were reported by interviewees in terms of accessing to health services. Because it was really, there's a base understanding that access to health is in those countries a universal right, independently of the person's migration status. However, there's still lots to learn as well, particularly in countries such as Brazil and Chile, where also health is supposedly guaranteed. But in the context of Brazil, we receive a lot of reports from our interviewees in terms of experiences reported by migrants of racism and xenophobia, both trying to access primary health services, but also the quality of the health received, and we know some of civil society organizations in Brazil, for example, they have been doing a long-term work in trying to deal with that racism and xenophobia, because people, despite that they have the right to access, they are not doing it in practice. Then in the context of Chile, we have other difficulties. For example, since there has been an increase of the politicization of migration due to the sheer numbers of Venezuelan displacement, the government of Chile, in that case of the previous president, Sebastián Piñera, tried to make a link between COVID-19 and irregular migration. Whether COVID arrived to the country to a Chilean person that was on holiday in Asia, not necessarily through a regular migrant. But the president and the Minister of Health came out in television saying, actually, we have to close the borders because these irregular migrants are bringing COVID into the country. We have seen this in Latin America before, in which a link is done between specific diseases and migrant communities. They did the same with TB, and at some point they did it with HIV. So we can see a direct connection being made between migrant population and disease, in many cases without any reasons or fundamentals to be done. So, and that already created an environment that put migrant population in a difficult situation, because some of them might take some kind of self-control measure of not going to health services, one, because they thought they were not going to be, attended, but also because they didn't want people to believe that they were the ones carrying the virus. So it really created a difficult situation for them. Now, this situation with racism and xenophobia really goes beyond the pandemic. I have to emphasize, for example, the work that some of my colleagues in Chile are doing, like my colleague Jafsa Reyes in the south of Chile, that she has been exploring the experience of racialization among Haitian migrant women in Chile, and understanding that health workers, for example, have about their maternity practices and how they conceptualize care and the provision that they give or not. So I think that one key point, there's access to health as a human right, which is welcome in paper, but there's still a lot to do in practice. The second point I wanted to make here is that it's related to border closures and maybe the limits that we can understand to some of these epidemiological surveillance, measures taken by the state. So in Latin America, like in many other parts of the world, one of the immediate responses from most countries of the region was to actually close their borders around mid-March of 2020. Now, this response was based on control and epidemiological surveillance, that it wasn't necessarily validated by the WHO, but that the countries justified as one of the protective measures. And at some point, many of the countries of the region had the borders closer. But some of our interviewees, in particular those working actually within health services, questioned those measures, because what happened is that the borders were closed, actually many people wanted to go back to their countries. They wanted to return, but because the borders were closed, they start to agglomerating in some border cities or in the capital in front of the embassies or the consulate, which actually create a health crisis in itself, because people were living in the street without the possibility of social distancing. They couldn't actually, access to hygiene kits or hygienic measures. So that became a focus of infection in itself. So border closures really didn't prevent necessarily the arrival of the virus, because the virus was already in the country, but actually create another mini health crisis. So there's something, the lesson learned there is that using, the virus to close borders, it generates other crises in itself, and people cannot really comply with this measure imposed by the countries. So really the response of control has to be addressed, not only for this crisis, but any other epidemiological crisis in the future. One of the key axes here was not only the health needs of the population that were waiting to go back to their countries. There's an issue, of course, as well, and this is completely an address of mental health and the difficulties that migrants and refugees were living in relation to not only the uncertainty of the pandemic, but also the radical uncertainties about the displacement and migration. So there's something about mental health that wasn't necessarily addressed. In all of this, regularization is a key aspect, because it is promoted by many of the countries of Latin America that we study, but there's limits to that regularization. So in some countries like Chile, for everything you need an ID. Even to go shopping, they can ask you for an ID. More, of course, to go to a health center, although you can still go without one. But in countries like Colombia, where the system is more irregular in the ways of, or more informal in the way of working, despite that the government imposed a regularization system that has been very praised, with particularly for the Venezuelan community, regularization is less important. So there are questions as well, to what extent regularization, which became a key message during the pandemic, is necessarily a key message to access to ensure migrants access to health services. Now, the last point I want to make, and I know I only have a couple of minutes, is really emphasize something that Erica already told us, and Marie and Nabila also emphasized, which is the adaptability of the civil society sector, the international organization sector, but particularly the migrant-led organizations. And they have a key role in the context of Latin America. In this case, we emphasize the role of social connection. So basically people that can put us in touch with other organizations, or, interpersonal, organizational contacts that they can provide us information in terms of, access to health, but also health practices. And these sectors, the civil society and the migrant-led, have to change very quickly the programs and their budget. They have to redirect, take their budgets and change immediately to cover their needs. And in that, they included huge campaigns in terms, I'm going to show you this slide. They included a lot of campaigns in terms what to do, what are the measures that the government is imposing on us, and how we translate this into Creole, into Arabic, into other languages, so people can actually know what's going on. This also tells us a little bit about the digital turn, because these campaigns happen at the community level, but also they happen through TikTok, Instagram and Facebook. So really people disseminate information that became key to disseminate the government measures in terms of the pandemic. And now, what is important here, other organizations like international organizations and civil societies at the beginning provided a lot of hygienic kits, like things people can clean themselves, some water and food parcels. But a lesson from there is that in many cases, they didn't have the knowledge of what people really need, particularly if they were in a situation of homelessness, for example, or they were living in agglomerated spaces where maybe the content of those parcels could be changed. So, and that also is maybe a learning that we can take for the future. I know that I am on my time already, so just to emphasize that we do have a website and all our publications are available there, but also we are happy to discuss more in the future if needed. I'm going to stop there.
Thank you very much, Marcia. I think just 3 points that I would highlight: your idea about this, the multiple contexts of crisis, this emergency concept related to whether migrants have inherent human rights or are the subjects of humanitarian assistance. The role of civil servants, I think, is extremely important, particularly the role of the municipal. Other speakers have raise the role of municipal authorities and these civil servants. It's kind of similar. And again, bringing up the role of migrant serving and civil society organizations. So I think all that might come up in the discussion. And just as we're formulating questions, I did want to now just 3 to 5 minutes move to the global, and let Lisa just talk about 3 of the lessons that we learned from our systematic review. So Lisa, please.
Yes, thank you so much. Hi, everyone. My name is Lisa Hitch. I'm a PhD student and a graduate research fellow at the CUNY Center for Immigrant, Refugee, and Global Health. And I just want to kind of bring it back to a little bit more global and cross-country perspective, and kind of incorporate all that we've heard. So at the center last year in 2021, we conducted a systematic review, and we were interested to see what types of factors of big cities either exacerbated COVID-19 impacts for migrants, or what factors of big cities supported the migrants in these settings. And I just want to note that a lot of the things that I'm going to talk about, we already heard in like the 4 speakers that we heard today, which I think really shows that we can learn from each other, and we should learn from each other from different local perspectives and try and see if it works for other contexts. So our systematic review, we included 29 studies. We looked at the studies that were included that looked at 29 different cities across the globe in 14 countries and in 5 big regions. And I just want to give a little caveat that whatever the findings that I'm talking about, they're mostly focused on European and North American cities. So what we found in the systematic review is the first and the biggest exacerbator of COVID-19 impacts for migrants in cities are pre-existing structural inequities. And that's something that Nabila also highlighted from India, where overcrowding, financial insecurity, barriers to accessing healthcare, they are not new to the COVID-19 pandemic. They're not new to refugee crises right now, but they have been pre-existing, for decades, for years. Then the second factor that we found was that the exclusion from government programs, from relief programs, has also exacerbated COVID-19 impacts, but e-governance was kind of a promising mitigating strategy. So for everyone who doesn't know what e-governance is basically an attempt to move all the applications and the forms that you need to apply for asylum or for a residency to an online space so that migrants and other populations are included in those. So again, this was promising, but again, there's still a lot of factors because a lot of migrants and refugees couldn't access these forms because they didn't have internet, or they didn't have the devices, or they just didn't understand the language. So for those two, our recommendation is that we need to address these structural exacerbators on an ongoing basis. So not just when the pandemic or a new epidemic starts, but now as part of pandemic preparedness, and that migrants need to be included in safety net programs and government relief funds and in local decision-making. And I just want to highlight that this is also in line with what Marie said about Denmark, which is kind of promising because we heard that migrants or refugees from the Ukraine, that they received temporary residency and that allowed them to access healthcare. So that would be a lesson that could be applied to other regions as well. And then another area that we looked at was the urban design, and we found that residential segregation, especially migrants that live on the edges of the city, and then they have to commute into the city centers for work and for services, that led to crowded public transportation. Again, we saw that in the presentation from Nabila in India. And so that was another very strong exacerbator of the COVID-19 impacts for migrants. And then the absolute biggest supporting factor of cities was the engagement of CSOs or civil society organizations. So because cities, they just have greater availability, greater accessibility to civil society organizations, those organizations were able to fill governmental institutional gaps. So they provided food, they provided cash assistance, translation services, and even childcare. And they really expanded their programs of their services and also moved it to the online sphere to access more of their clients. So, and again, like this is also something that we've heard a lot today from Erica, but also from Marsha, that we just need to strengthen the civil society organizations, but not just help them or support them, but also to form partnerships between the government and the civil society to make sure that these efforts are not just to fill gaps, but actually systematic and can be used as part of pandemic preparedness. And that's also our recommendation. And our last recommendation is also that we need to look into urban designs that could mitigate these COVID-19 or other health impacts for migrants in large urban areas, because we did not find a lot of research on that. So those were our findings from our systematic review. And again, I can just reiterate that really captured what we heard today from all these different regions. Thank you.
Thank you very much, Lisa. As we're getting questions in the chat, I really wanted to come to this idea of, because this has come up a lot and it's raised by many, and it's also come up from some of our participants today. This whole idea of the role of civil society. Every single speaker, and certainly our systematic review, highlighted the role that civil society plays in times of crisis. It's not only health crisis, but we were focused mainly on health crises. On the other hand, most of these organizations are operating on a shoestring without a lot of government support, without even a lot of connection to government, and sometimes in opposition to government. So what are some of the things that we can recommend or think about in terms of strengthening the role that these civil society organizations play without allowing government to abdicate a basic responsibility, which is to provide health services to everyone living in their jurisdictions? So what's the balance there? Anybody? Nabila?
Yeah, I'm just conscious of the fact that I actually didn't talk about the civil society role because I was so focused on looking at the role of the state and the lack of state response, or the limited state response to the issue, and the unique issue in not just India, but in the case compared in terms of India compared to the other cases presented today, is that it is, like the states, a federalized large country with a central government working sometimes at odds, so working with the 28 states that make up India at the moment. So civil society was obviously a massive presence in each of the COVID waves, usually at local level, at state level, but probably most strikingly in trying to coordinate or bridge migrants or bridge beneficiaries with the government. So, for example, getting over that hurdle of not having fixed proof of identity or not having sufficient ID cards, which I'm seeing as a massive theme throughout all of the cases presented today, kind of filling in applications for migrants, providing that bridge to enable migrants to access a pretty robust set of entitlements and food subsidies and schemes and public health care. They are there for Indian citizens, but they can't be accessed because of these hurdles, which I think is really rooted in, somebody talked about racism in the chat. I think it is rooted in India, it's a discrimination based on things like caste and religion rather than race as we understand it in the West, but it is based on discrimination or dehumanization of some sort. So, so the civil society, broadly speaking, because it's different in each state in India, is there to act as a bridge. And actually a lot of the advocates, a lot of the activists have been working on things like right to food, right to the city, right to resources. There's a lot of rights-based movements, especially in this current government in India, the previous Congress government, where even though there have been very admirable judicial reform, sets of judicial reform to increase the access to food subsidy schemes for households that are living under the poverty line, etc., migrants still remain explicitly excluded from these legislations. So even though advocacy groups might still, put these in draft bills, put these forward to the government, put these forward to Supreme Courts and say, this is what we should do, this is how we, help address this issue, they're still routinely, explicitly excluded. So I just wanted to highlight that particular situation with COVID and even before COVID, right, in terms of the role of civil societies and migrants specifically in India.
Right. So civil society as a bridge. Interesting.
A bridge, but there needs to still be there still needs to be more explicit recognition of the plight of migrants, labor migrants. Sorry.
Right. Does anyone else want? Yes, Erica.
No,
Second, Marcia want to say something?
Marcia,
I can follow you, Erica. If you want, you go and I follow.
No, just thinking about this question, Kathleen. I think that the response from civil society, it was based on solidarity also, but solidarity isn't transformative. Solidarity has a contradiction. So what happened during the pandemic was based on solidarity, motivation from civil society, but doesn't change anything. So for be transformative, solidarity isn't enough. For this reason, I put that the autonomy, self-management, self-determination, autonomy in terms of economic autonomy on the part of the civil society, but especially refugee-led organization, association, has to be recognized. Because in this manner, in this way, you systematize, and you formalize, and it's not just solidarity, because solidarity reproduce this kind of inequalities, racism, inequalities in the access of the services. Until there isn't a very auto-representation from people on the move in the policies, in the this decision about health, for example, solidarity isn't enough. It's very valuable, but isn't enough.
Not
Isn't
enough. Good point.
transformative, I think, but there are many academics who speak about
Great.
it.
Marcia.
I completely agree with Erica on that point. Actually, the way that we have discussed this, Erica, we moved the idea from solidarity to really thinking about the scope of resistance. So in the context of Chile, we have come out to conceptualize this as inclusive resistance, because migrant-led organizations are actively resisting some of the exclusion that come from the state, but at the same time, through their practices, they include the neighborhood, the local community, you know, so they ended up being more inclusive than the exclusive practice of the government. The same we have done in the UK. We recently have submitted a paper with colleagues thinking about how the refugee sector in the UK battles the hostile environment, and by doing that, so we think about practice-based resistance. So they support migrants and refugees through practice of care, but we can say, but care in a way that actually resists the hostile environment at the same time, and ended up being transformative, as you say, that goes beyond the solidarity. So it's not empty solidarity, there's a change there. And I wanted to go back to something that say Nabil as well, because I completely agree. One of the things that we see in Latin America is that these different configurations between the different actors, civil society, migrant organization, international organizations, and the state, in many cases, ended up by the state taking advantage and disassociating themselves with the care and the responsibility that they have for the humans in the territory. And the civil society organizations, they keep telling us all the time, us being humanitarian agents is not a work that we want to do. We want to come back to our plans that look at long-term inclusion and social cohesion, and not necessarily being providing, you know, humanitarian kits or food parcels. We want to do something else than that. Right now, we have these basic needs that we have to cover, but it's not what we want to do in the long term. So I agree with Nabila, it could be a bridge. And in some cases, they are including the discussion, but they want to be there, not in a tokenistic way, but in a specific action-focused way, thinking about the long-term inclusion and social cohesion.
Yeah, and I think this point, we also found it in other work we've done with migrant serving organizations in New York City, that organizations actually see being the bridge, helping people navigate and access services, they see as an appropriate role, but having to provide all those services is not what they see as their role. And that's what's shifted in the wrong direction during the pandemic and during other health crises. Another question that's come up is just about municipal or local authorities. And Marie, you mentioned this, so maybe you'd want to start. I think also a couple of other speakers mentioned this role of, it's kind of when there's a natural disaster, it's always the people that are actually on the ground are the most important, make the biggest difference in the first 24 hours before everybody else can come in and offer help. It was also, we found in our research that the municipal authorities, and Marie kind of made this clear in her presentation, they were left holding the bag. I mean, they were left responsible for these groups before national and provincial and all other policies could catch up. So I don't know, Marie, if you have any thoughts about what could be done to lessen the time that municipal authorities are left by themselves, or that they're empowered and strengthened in a way that would be useful.
Yeah, I think that's a really key point. I don't know. Hopefully, I mean, there could be some sort of support earlier to municipal workers from the more sort of national strategies could sort of involve supporting them. I think there was a lack. We've seen a lack of that. So I don't know, maybe some sort of systems in place that could do that, because if not, it's too much a responsibility, just like we talked about now with civil society. It's good if they can bridge or fill in, but when there's other systems that are supposed to be taking the responsibility, for instance, for health, and you come to a limit, and actually it becomes maybe also unethical or difficult if you can provide the right sort of help and etc., then it's leaving much too much responsibilities on people who are not actually equipped or meant to have that kind of responsibility, and that's a very frustrating and stressing role to have. I'm not sure I have the answer really, Kathleen, but it could be good if it was sort of somehow in the future built more in the structure of the municipalities and the support the local workers on the ground get, but also from a national strategical point of view.
Great. Thank you, Marie. We have another question coming up about the desire to hear more about advocacy strategies to better engage government leaders in some of what's been learned. So I guess it's this classic, what academics are recommending and what policymakers are actually doing. And, you know, how do you bridge that divide? And this participant raises some of the things that we've seen in the US, like the use of the Title 14 at the border and setting up camps in the middle of New York City for migrants that are being bused from one state in the United States to another state. Like when you see things like this happening, and some of the things that you've raised in your presentations and in your thoughts, like how do we get government leaders' attention to apply these lessons? And that might be a good point on which to ask each of you just to offer a couple of thoughts as a wrap up to the webinar. So Nabila, maybe we'll start with you.
Yeah, sure. I think I know it's not a very kind of sexy answer, but it is a long, and I'm actually reinforced by hearing everyone's presentations today, which were absolutely fantastic. Thank you so much again for the opportunity, is that we need to take a longer term, there needs to be an attitude change that stops differentiating and stops differentiation and preferential treatment of different groups of migrants. We've seen it in, Marie raised it with Denmark, very strikingly. It's not just for Denmark, it's the whole of Western Europe as well, where we treat Ukrainian groups completely differently to another big wave of refugees from Afghanistan just the year before. Why do we treat certain, migrants within India, labor migrants, those who are working already in stigmatized conditions, as lesser humans than other citizens? Why in Latin America is this racialization that's going on? Why in Portugal are certain people, preferred or not preferred? And it's because of an embedded attitude towards seeing migrants as different, as less than human or lesser humans, or just different gradations of humanity. Because if we have an attitude change, media, government, obviously us as researchers as well, practitioners, etc., then we can start to come up with solutions in terms of why do differential people need. We can start to come up with solutions in terms of material barriers. So the other big theme I'm seeing is the documentation. A lot of these great schemes are out there, great initiatives by civil society and by government, but it's down to bureaucracy of not being able to process that documentation. In emergency situations as well as longer term situations, that is the barrier to kind of granting migrants their entitlements and their rights. So that attitude change in the long term, but also using things like technology, like Lisa referenced, there's a lot of work still to be done in contexts like India in terms of digital technology, but thinking of different ways. Let's advocate for the government. We don't need to advocate because in the sense of like, we've already seen the worst of what can happen. Everyone's seen it. Whatever you're describing in New York and wherever we're talking about, governments have seen how awful it can be. So I think now it's about coming up with solutions and coming up with, using innovative things to try and address this. Sorry.
Okay, thanks. So innovative, let's be innovative. Marie?
Well, I'm not quite sure what will make politicians. I mean, my hope has been a lot that COVID has really been an eye-opener for at least for our national boards of health and then policymakers, understanding that we have to think about many more nuances and dimensions, and we really have to know that we don't necessarily by our normal preventive strategies reach all parts of the population. And somehow, at least in Denmark, this has made us be more open to co-creation with having local partnerships with different groups of migrants. And I'm hoping that somehow this has been an eye-opener that maybe will continue to have expert groups on migrant health, etc., in the boards of health, and that the Ukrainian refugees, what we've done here can be a good example for future interventions. I know we're lagging behind on supporting municipalities, etc., but overall there's been this this kind of much stronger focus growing from COVID and from Ukrainians. So I don't know, maybe we can somehow use this as a basis for future advocacy for all the different migrant groups that we've been talking about and that has been mentioned here today.
Well, thank you very much, Marie. So collaboration.
Mm.
Erica.
How we implement what we learn, how we can, how do we get to how our leaders to listen and implement? I think it's a very difficult question, but
Just one thought.
I think it's very complicated because, for example, in Portugal, there is a competition between different organizations about who about asylum seekers, who take care of asylum seekers, and this is one point, critical point. Then there is competition between the organization. So because refugees are represent a business, and I think it's about stop to speak about refugees and start to speak about citizens, maybe. So not to address, like I say in the speech, not address the problem like refugees, but speak about citizens. So maybe okay.
No, that's good, Erica. I think that's a good point about the framing of the issue. So great, thanks.
Thank you.
Marcia, last word to you.
So it's so difficult to have the last word, but just to say, I agree with colleagues that I think collaboration is key. There has been a strength of, and one of the tiny good things is that we are communicating more to these spaces, not only with other academics and researchers, but at the same time with migrant-led organizations, with the civil society organizations, and even with governments. I have been in a lot of workshops with government officials trying to find dialogue and create spaces of understanding and trying to understand as well how they work in very constrained environments, that there's a lot of politicization of migration, but actually challenging though. I can see that there is a question as well about civil society. Very briefly to say, this happened in Latin America and in the UK, because the hostile environment now not only applies to migrant population, also applies to people working with migrant refugees. So one of the challenges is the short-term budgeting, for example, that they have projects for 1 year or 6 months. So there's not sometimes the capacity to transfer methodologies or to keep the historical memory of these organizations. And I know colleagues like the Scottish Refugee the Refugee Council in Scotland and other colleagues working with the New Scots, for example, in the UK, have been doing a lot of efforts in strengthening this partnership in the same way. If we don't have the resources, how we can keep this methodological, knowledge, and how we can transfer this knowledge so we can keep collaborating, working together. I know we are on time, so I'm going to leave it there, Kathleen, but thank you so much to all colleagues.
Thank you very much. So I think we had the ideas of innovation, collaboration, framing, and in communication and resources as being some of the issues that might help bridge, some of the concepts that might help bridge the gap. I just want to close by thanking Nabila, Marie, Marcia, and Erica, and Lisa so much for their interventions, for the active participation, and for the support and collaboration of the Global Society for Migration, Ethnicity, Race, and Health, and the European Public Health Association Migration Section. Thank you so much, and we hope this will be the first of many productive discussions. Thank you very much.